Okay, hello, good afternoon. Thanks for joining us today. My name is Dr. James Scott. I'm an orthopedic reconstructive surgeon at Mercer-Bucks Orthopedics. Just a little bit of my background. My training in orthopedic surgery was at the former University of Medicine and Dentistry in New Jersey, the School of Osteopathic Medicine, and my fellowship in adult reconstructive orthopedics, which is a fancy way of describing complex hip and knee surgery. Was at the University of Virginia in Charlottesville. Just as a disclosure, I have no relevant financially related to this talk, purely informative, and I hope you enjoy the next half hour or so. So just a basic overview of what we expect to talk about today. We want to discuss some of the common traits and findings of arthritis as it pertains to the knee. We discuss the scope of the problem, and more importantly, the treatment algorithms and options to limit pain, maintain an active lifestyle. So first things first, what is knee osteoarthritis? Commonly occurs in older individuals, but it can certainly occur in folks of all age categories. Some of the causes are post-traumatic, meaning previous injuries, infections, inflammatory conditions such as rheumatoid arthritis, lupus, psoriatic arthritis, certain developmental abnormalities or anomalies, and hereditary components. There is a strong genetic component to arthritis. People that have family members with arthritis are unfortunately a bit more prone to develop arthritis in their lifetime. It is a degenerative cartilage disease that causes cartilage found in the healthy joints to break down. It can occur in any joint in our body, and for today's purpose of today's talk, we're going to discuss how that happens in the knee. It's one of the most common forms of arthritis and one of the leading causes of disability, according to the AEOS, which is the American Academy of Orthopedic Surgeons. And it's estimated that roughly 46 to 50% of the adult population will develop arthritis in their lifetime. So, general progression of disease, how does it start and where does it go? So early on, we consider it mild disease or mild osteoarthritis. Commonly associated with sports-related injuries, for example, where you can get minor defects in the cartilage. You get small areas where you lose cartilage over time. And this is commonly associated with mild pain, periodic swelling, and stiffness. Sometimes typical imaging, and when I say standard imaging, meaning an X-ray, it can be normal. Sometimes more advanced imaging like MRIs might be necessary to even identify arthritis at the early stage. As things start to progress down the line, we call it mid or moderate arthritis. Patients start to develop some increased pain. They may not be able to do as much as they used to do. They may have to start changing some of the things in their day-to-day routines or in their lifestyle, maybe give up certain sports or decrease what types of sports or activities that they do. You may start to see some changes apparent on X-rays. You may start to see some narrowing of the joint space. You may start to see some bone spurs forming. And when we start to get to this phase, we can start talking about some particular treatments and some surgical interventions at that time. When we progress along to late stage or severe arthritis, and this is one of the leading causes of disability, typically accompanied by severe pain. Simple tasks like walking and climbing stairs can be very challenging, and usually this involves impairment of activities of daily living. And this is generally considered to involve, most, if not all, of the major compartments of the knee. These are just some X-rays that we would typically obtain in the office, which can demonstrate what arthritis looks like. And so when we get a knee X-ray and we say, oh, we can see arthritis on the X-ray, we look for different changes. So if you look at the X-ray on the left side of the screen, this is what a normal knee looks like. This is the joint space. That's the space between the femur and the tibia. And when you have this open space like that, that generally indicates that there is thick and healthy cartilage. As we start to progress and we have more advanced disease, if you look at the outside part of the knee, this looks pretty normal, kind of like over here. When you look at the inside, there's almost no space between the femur and the tibia, indicating near complete loss of cartilage. And we look at the knee X-ray on the right side of the screen, there's almost no space on the outside portion of the knee. The space is completely closed down on the inner portion of the knee. This is severe arthritis that encompasses all major aspects of the knee. When we start to develop the symptoms of arthritis, we start to develop a treatment algorithm. And what that means is that we start to initiate different treatments or lifestyle changes to help minimize the symptoms and to really try to maintain as active a lifestyle as possible. First things that we generally advise are weight loss, physical therapy, weight loss to help with decreasing stress on joints, physical therapy to help with strengthening, maintaining range of motion and flexibility. Common medications that we would initiate around this time are non-steroidal anti-inflammatory drugs. And these are medicines that are commonly found over the counter. Ibuprofen and naproxen are common over-the-counter anti-inflammatories. Meloxicam and Celebrex are some prescriptions that might be prescribed. And there's injections that we can do. Typically, injections in the knee joint are usually steroids or something called hyaluronic acid. And we'll get into that a little bit more. We generally advise some changes in the types of activities that are done to minimize provocation of a painful or irritable joint. And that might be avoidance of higher impact type activities, and sometimes using assisted devices or different ambulatory aids. And that can encompass things like knee braces, knee sleeves, walking sticks, canes, or sometimes even a walker, depending on the severity of the pain and dysfunction. The last treatment that we have to offer is surgery, and that's generally when the arthritis is non-responsive to these non-surgical treatments. The pain and dysfunction is really significantly impacting activities of daily living and negatively impacting quality of life. All right, so just kind of take a little deeper dive in some of the non-surgical treatments. We talked about activity modification. So exercise is important. We want to keep an arthritic joint moving. That helps minimize stiffness. It minimizes weakness that can occur from disuse, and can help improve overall and maintenance of range of motion. So we want aerobic type exercises, and those are things that generally get your heart rate up. And so it's good for cardiovascular health. Good adjunctive treatment for weight loss, but we want low impact. So exercise, bicycle or cycling, elliptical, which is similar to cross-country skiing type motions, and swimming. And swimming is sort of a broadly encompasses exercises that are done in the pool. Different braces or orthosis. So we generally start with something pretty simple, a compression sleeve. Everybody, or a lot of people, have heard of things like a copper fit. Doesn't have to necessarily be that particular brand. I only bring that up just as something that's familiar to some folks. But something with like a elastic or neoprene type material to provide a little compression and feeling of support. There are off-the-shelf braces that have hinges that can provide a little side-to-side support. And we usually move on to these types of braces when patients have some feelings of instability, that the knee wants to give out on them, or if they're having some difficulties on uneven ground. And then there are some custom braces. The most common custom brace that we use is something called an unloader brace, and that actually helps decrease some of the load and stress on the affected aspect of the joint. We typically use these types of braces if patients have arthritis that's isolated to either the inner or outer aspect of the knee. They're a little bit more expensive, they're a little bit more cumbersome to wear, and they're not always covered by insurance. But they are something that can be a useful treatment if properly indicated. As we move along, when we're talking about weight loss, we're looking at something called the BMI, or body mass index. What's generally considered to be a healthy BMI is 25 or less. What really concerns us is if the BMI increases to over 40. That's generally been associated with increased health risks, cardiovascular disease, pulmonary disease, other vascular disease, and also increased risk of surgical complications. So the basic importance of weight loss is to decrease the stress of an arthritic knee and to improve overall pain. And if we think about, how much stress does weight loss take off the knee, figure about 4 times your body weight magnified through the knee when walking on level ground, and roughly 7 to 8 times body weight when you're going upstairs or walking on inclines. So a 10-pound weight loss or weight gain can translate into roughly a 40 to 80-pound decrease in stress on an arthritic knee. So medications, NSAIDs, we briefly talked about, different brands and types, generally effective in folks with mild to moderate disease. They can provide significant improvements in pain, but they do have some limitations in their use. Patients that are taking blood thinners, which are anticoagulants, that have kidney disease or different GI disorders such as ulcers or gastritis, may not be able to tolerate these medications or shouldn't take them at all. Acetaminophen, which is Tylenol, can be a safe adjunctive medicine to NSAIDs. They are not as effective when used alone by NSAIDs. And again, they have limitations when used in either high doses or if combined with alcohol. Opioid or narcotic medications are generally not recommended in the treatment for osteoarthritis, and there are some significant problems that can arise with tolerance and dependence. Commonly asked questions are what kind of are there any supplements that I can take, vitamins, things that will help with the arthritis? So common things that I advise patients to take. So fish oil is one of them. Generally has uses for joint health, cardiac, and neurologic health. You should always consult with your primary doctor before starting. Folks that have an abnormal lipid profile, high triglycerides or cholesterol, may have that impacted by fish oil, so it's always important to discuss that with the primary. Turmeric is a common food supplement that is thought to have some anti-inflammatory properties and generally can be safe and moderately effective in treating some of the more mild to moderate symptoms. Glucosamine chondroitin is a supplement that's been around for decades. Unfortunately, studies have not shown a lot of clinical benefit in either the prevention or progression of patients with knee arthritis. And finally, injections. So this is also one of the most common procedures that we do in the office. A corticosteroid injection or a cortisone shot can be very effective for short-term pain relief. Studies have shown that the effects last for at least 1 week. Commonly, we see patients report anywhere from 8 to 10 weeks of good pain relief. They are repeatable, meaning that can be done as frequently as every 3 to 4 months. Typically, the use of these medicines are limited by, number one, their effectiveness. If they're not providing good pain relief for a long time, then we generally advise not to continue doing them. Sometimes patients will have some side effects, especially diabetics, where their blood sugar can be elevated for a short period of time afterwards. So viscosupplementation are adjunctive treatments that we use to steroids. They are hyaluronic acid, and that's similar to a polysaccharide that's found in healthy joint fluid. Relief can be similar to NSAIDs and can potentially provide a longer-term benefit than corticosteroids. They can be performed as frequently as every 6 months. They are more expensive than steroids, and they're not always covered by insurance. And injections that are more under investigation, PRP or platelet-rich plasma, or autologous stem cells, and that means they're harvested from the patient, either from adipose tissue or from their own bone marrow. They're investigational studies to really determine what's their role in the treatment algorithm of patients with arthritis, and what's their impact on overall pain relief, as well as is there any impact on delaying or slowing the progression of arthritis. And those are questions that have not been fully answered as of yet. All right, so when we're talking about surgery, we're talking about surgical reconstruction of a damaged joint to help restore alignment, decrease pain, and improve function and quality of life. And the spectrum of options really depends on the degree of arthritis or the degree of disease and the magnitude of symptoms that we're dealing with. So the least invasive and simplest type surgery that's available is something called an arthroscopy or a knee scope. Now, its role in the treatment of arthritis is not very well defined and is actually not recommended for purely an arthritic knee. Typically, we're doing arthroscopy to address issues that are present in conjunction with arthritis, such as meniscal tears If there are isolated cartilage lesions that can potentially be grafted or reconstructed, or if there are loose bodies or a significant amount of what we consider synovitis that's interfering and causing pain. If there is radiographic significant arthritic change, meaning that we can easily see arthritis on the x-ray, the role of arthroscopy becomes much more limited and the benefits are much lower. Partial knee replacement or partial knee arthroplasty is generally performed for what we consider moderate arthritis that is isolated to a single compartment of the knee. And finally, total knee arthroplasty, which is the most common procedure that we do, is for late stage arthritis that's not responsive to non-surgical means. So again, arthroscopy, fairly limited use, not a lot of benefit compared to placebo when done purely for the diagnosis of arthritis, but again, may be recommended if there are symptomatic meniscal tears in addition to mild arthritis. However, the presence of arthritis does lead to poorer outcomes and more unpredictable outcomes. So I'm going to talk briefly about something called an osteotomy. It's not something that we commonly do anymore, but really for completeness and for some of our younger patients, this might be something that is an option. It's basically cuts in the bone to change the overall alignment in the knee to offload the affected area of the knee. So basically the surgery, what we is called a high tibial osteotomy, and basically opening or closing a wedge to change the knee alignment. We're doing this typically to offload the medial or inner compartment of the knee. There's typically no reason to modify the types of activities after this is all said and done. Some of the contraindications if patients have inflammatory arthritis, if they have more than one compartment arthritis, or if they don't have, or if they've had their meniscus removed in the past. They do have to have good range of motion. It needs to be corrected to a particular a fairly tight tolerance, and the success can be variable over time. Majority of patients have good follow-up, good results at about 2-year follow-up. However, those results do start to decline over the course of about 10 years. Some of the limitations of that, it's less durable over the long time. It may not fully resolve the symptoms. Arthritis can certainly progress, and having this operation can make a future knee replacement more difficult, and the outcomes may be less satisfactory. All right, so when we get to knee replacement, it's one of the most successful operations that we do in orthopedic surgery. They have roughly a 95% success rate over 10 years. Historically, this operation has been performed in older, less active individuals. And when I say older, we're talking about over the age of 75 with relatively low physical demands. Over the course of the past 15 to 20 years, there's been a significant decrease in the age of patients that are having knee replacements done, which reflect an increase in the incidence of arthritis, which is likely reflected as an aging population, better health of our aging population, and higher physical demands and expectations of what folks want to do. Patients want to do things for a longer period of time. They want to stay active longer. They want to do more things. So when we're talking about total knee replacement, again, it's indicated for end-stage arthritis, the failure of non-surgical interventions, and the patients need to be medically stable. Doesn't mean you can't have any medical problems, but the diabetes, heart disease, high blood pressure, etc., should be controlled and well managed. What knee replacement involves is removal of diseased cartilage and some of the underlying bone, and we replace that with a roughly even thickness of metal and plastic. Total knee replacement is considered the gold standard of treatments for arthritis of the knee, has proven long-term survivorship greater than 90% over 15 years with a high satisfaction rate. Some of the limitations that have dogged us over the years, it is an invasive operation. Rehabilitation can be difficult, can be challenging, and the recovery can be long. Generally, it takes about 12 weeks for patients to feel largely that they've recovered from the operation. And in some instances, the disease pattern in the knee, you may be removing some healthy cartilage and tissue as well. Which segues into something called unicompartmental or partial knee replacement. This is indicated for arthritis that's isolated to, as it's in the name, just one region of the knee. typically associated with a shorter recovery time compared to total knee replacement. A little bit more natural feeling to the knee since more of the native knee tissue is preserved. There are some greater limitations, and the indications are a little bit narrower compared to total knee replacement. Need to have a stable knee, needs to have minimal deformity. And what this means is roughly 10 to 20% of patients that have knee arthritis would meet indications for a partial knee replacement. And these are just historical. This is kind of a busy slide, but this just basically shows the progression of who would be indicated for a partial knee replacement in the past versus present. And if you look at the indications on the left-hand side of the screen, based on that criteria, less than 10% of patients would meet that. As techniques have evolved, as implants have evolved, and as we have a better understanding of how patients do following these types of operations, we've been able to expand the indications to a degree, and a much greater percentage of patients may fall into that category of being indicated for a partial knee replacement than in the past. So some of the benefits: only targets the diseased area, preserves unaffected regions of the knee. Limitations: it's actually a little bit harder to do than a total knee replacement. We have the stricter indications, and so the majority of the patients would still have arthritis elsewhere in the knee. And potential long-term outcomes, there is the concern of developing arthritis elsewhere in the knee. So if we have a partial knee replacement in this compartment here, which looks like the outer compartment of the knee, the medial compartment or inner compartment can develop arthritis over time. Sometimes arthritis can develop under the kneecap, which can become symptomatic and necessitate surgery in the future. All right, so we've kind of gone through all of the non-surgical treatments. You've talked with your doctor about what are the things to do. Pain has progressed to the point where you want to consider surgery. Well, now what? All right, so preparation. What do we do when we're deciding we want to move forward? So typically you'll get 3 things in the office, or 2 to 3 things. Clearances from the dentist and from your primary care doctor. So dental clearance is necessary to minimize the risk of infection associated with things in the mouth, such as cavities or need for other dental work. And medical clearance, just to ensure stability of underlying medical conditions, whatever they may be. In some instances, a cardiac clearance, so a visit to the cardiologist may be indicated if there is a history of pre-existing heart disease or if there are any concerns in preoperative testing. Other clearances, which are less common but may need to be performed if there's any lung disease, sometimes a pulmonologist may need to be involved. If there's any underlying kidney disease, sometimes a nephrologist or a kidney doctor might need to be involved. But these are generally the most common folks that we get involved there. Sometimes we'll do something called prehab, which is preoperative physical therapy, and that can help improve conditioning, strength, motion, and studies have shown that it can ease the postoperative recovery. It can make it a little bit easier to achieve the goals and make the recovery go a little bit faster. So typically associated with a longer recovery, traditionally associated with a long hospital stay. Now, over the last 20 years, hospital stays were over a week, and they have decreased to just under 2 days. A greater emphasis has been placed on rapid recovery protocols, early discharge, and at this point, our goals are trying to get patients, if they have to stay in the hospital, home within a day. And in some cases, we can do same day total knee replacement where we get patients out on the same day of surgery. And so historically, knee replacement is done almost entirely in the hospital. That's not the case anymore. In selected cases, patients that have few underlying medical conditions, have good support at home, it can be done in the outpatient surgical center. As far as recovery, typical things to expect. Patients would go home, whether it's the next day or the same day. Our expectation is patients will go home. In some cases, patients would need to go to short-term rehab. And again, that depends on what their needs are from a conditioning standpoint, what their setup is at home, and how much help and assistance they need at home. Typically, we do in-home therapy for about 2 weeks, which is typically, again, followed by outpatient therapy for about 4 to 6 weeks. We generally see patients in the office about 2 weeks to inspect the wound, remove staples, and basically gauge what their early recovery is. We generally allow patients to start driving in about 4 to 6 weeks, depending on how much pain medicine they're using and whether they had right or left-sided surgery. Typical time out of work really depends on occupation, but the expectation is between 6 to 12 weeks, and that is variable whether the patient has a more physically demanding or less physically demanding job. And finally, the last thing I'm going to touch on is some emerging technologies to help with knee replacements and help us do the operation better and hopefully improve long-term outcomes. Typical things that we are talking about with additional technologies besides developments in improved materials to help improve longevity of the devices themselves and minimize wear. We have things such as navigation, robotics, and what's on the horizon are things like augmented reality to help enhance accuracy and reproducibility with knee replacement. At this time, these tools have not supplanted the traditional means of doing surgery and have a more complementary role in particularly complex cases. Their role has not been clearly defined in routine situations or more or less complex situations as far as what their long-term benefit is. And so just some common questions that patients will ask. When's the right time to have a knee replacement? Can you wait too long? How long can you expect it to last for? Can I play golf or be involved in other sorts of sports? And what happens if something goes wrong, either in the short term or in the long term? So when's the right time for a knee replacement? It's entirely patient specific. It depends largely on the severity of the disease that the patient has. It depends on how well non-surgical treatments work, what their expectations are and what their demands are, how active do they want to be, and how well can they do the things that they want to do. And are they medically frail, or are they generally in good health? Can you wait too long to have a knee replacement? No. I'd rather have patients be ready to have a knee replacement and then versus prematurely having a major invasive operation done. And it's generally not possible to wait too long to the point where a knee replacement cannot be successfully performed. As far as longevity, data shows that knee replacements, again, have roughly 90% survivorship at about 15 years. Over the course of between 15 to 20 years, we start to see increased risks of things like wear of the plastic, potentially loosening of the implants, and potential failure of the prosthesis. Numbers I quote to patients in the office is usually about a risk, 0.5% risk of failure per year, which again translates to roughly 90-95% survivorship at 10 years, and about 80-85% survivorship between 15 to 20 years. Can you play golf again? In general, patients can resume low-impact type activities such as golf, doubles tennis, swimming, cycling, walking. I have patients that have cross-country skied. I have a couple patients that are downhill skiers. It all depends on what your activity level is and what your demands are. We generally advise against participating in high-impact activities, and those are things like running, jumping, or collision sports, which most of our patient population are not generally involved in at this time. And what happens if something goes wrong? And that's really what we talk about. If a patient has a complication, if they have a fracture in the future, something, if they fall and breaks, if something wears out over time, if there's an infection. These are things that we can discuss in the future, and we can discuss at the time of the office consultation. There's possibility of revision surgery in the future, where the operation can be redone. We try to make things as perfect as we can initially, so we're not dealing with these potential problems in the future. Patients with high physical demands, that are basically younger than the age of 50 are unfortunately at higher risk of having the need for revision in their lifetime, but these are discussions that we have on an individual and patient-by-patient basis. And that's what I have for my presentation today. I appreciate everybody who logged in and stuck around to watch. I'm here to answer any questions that you might have. Looked like a couple came through on the chat while we were talking earlier. So my first question here: surgery for severe arthritis mean getting rid of the arthritis or doing total knee replacement? So the answer to that question is actually yes, because we're doing both of those things. So surgery for severe OA, osteoarthritis, is a total knee replacement. Now, total knee replacement gets rid of the arthritis. Now, the arthritis is a degenerative problem. And so by removing the cartilage in the knee, you're removing that arthritic problem. So you can't have arthritis again in that joint once it's been replaced with a total knee replacement. Caveat to that is, and I try not to be confusing here, if you've had a partial knee replacement, there is still native cartilage in the knee, which can potentially become arthritic in the future. But if you're having a total knee replacement, the arthritis is gone at that point. All right, so as far as this is a more general question towards treatments such as injections. So as far as injections none of the treatments are necessarily mandatory. But before doing a major operation, we do like to see that something has been tried, and those somethings, if they're working or if they're not working. Injections such as steroids can be very helpful because number one, they can make you feel better, and number two, they can help sometimes differentiate if there's things that are causing pain around the knee that are not necessarily from the knee itself. Now, I generally advise steroid injections at least one time, just for a pain relief benefit. Now, because some of the other injections like viscosupplementation, PRP, stem cells can be a little less reliable than steroids, it's not necessarily mandatory to go through all of those types of injections if you had a steroid injection which wasn't terribly helpful. And there are significant arthritic changes on our x-rays. All right, so I do have a question about knee revision surgery. That is part of my arsenal of surgeries that I do. As an adult reconstructive surgeon, we do straightforward hip and knee replacements. We do complicated hip and knee replacements, whether there's deformity, prior surgery in the past, and we do revision knee surgery. And that means that you've had a knee replacement before, and for some reason, the knee replacement is not functioning properly. That is something that we can certainly discuss in the office. But we do knee revisions, and it's actually about 15% of my practice. I have a question about how to differentiate arthritis versus a ligament injury. And a cartilage tear, when we talk about a cartilage tear, generally we're referring to like a meniscus tear. So physical exam is number one. Imaging, number two. So you can see arthritis on an x-ray. You can't see a ligament injury unless it's a really significant injury where the joint is unstable, and then you can see some findings that would raise your suspicion to it. Ligament and meniscal injuries are evaluated with MRIs. So if we have, if a patient has knee pain, and depending on how that pain started, whether there was an injury or if it started just kind of gradually over time, that will help determine what sort of imaging to get. We always start with an x-ray to look at the bony relationships. If that looks relatively normal or the physical exam is indicative of something else, then we'll commonly get an MRI or magnetic resonance imaging to look at the soft tissues around the knee. And that could be ligaments such as the MCL, LCL, ACL or PCL, and the meniscus, the medial or lateral meniscus. So sort of a question about different types of prostheses that are problematic. So there have been some prostheses in the past that have had some issues. And what we mean by issues, it means that the rate of revision or failure is higher than expected. So when we say less, about 0.5% risk of failure per year, if a particular implant is failing at a rate greater than what's expected, then it starts to raise some issues and concerns that perhaps there's a problem with either the design of the implant or some other factors that require further investigation. There have been some implants that have been recalled in the past. We presently are not using any implants that are under investigation. The particular implants that I use have been proven over the course of the past 15 to 20 years. The design has evolved over that time, but it's the design it's based on has a very long track record of success and reliability. We try not to use, at least for me, I try not to use an implant that's released immediately to market. I do like to see at least 5 years of data to support its use and look at whether there are any problems over that time frame. All right, so there are some more specific questions about timing of pain and when that might be. Sometimes folks will have some more pain at nighttime than during the daytime, and it can be a function of as you're using things, as you're using your knees throughout the day, that does create a low level of inflammation. When you stop that, the knees become painful. When you're not doing anything else, there's nothing to really distract you from what's going on. It can be made more difficult to get some rest at night. Sometimes there may be other factors that are extrinsic to the knee itself, which might be confounding why that's happening, and that's something that might be best answered with an exam and in the office. As far as different types of fish oil, generally things that we look at are fish oils that are high in omega-3 fatty acids. I don't have any information specifically as far as is there one type that's more beneficial than another. That is something that might be best addressed with a PCP or primary. And there are even some prescription type omega-3 similar to fish oil that can be useful as a supplement. As far as different types of surgery that we do outpatient, since while this is a knee replacement talk, we also do hip replacements. So hip and knee replacements are both being done now in the outpatient setting in select individuals for the same reasons that we discussed for knee replacement and the same types of indications. Generally a healthy individual with good support at home.
I just wanted to thank you for taking the time to educate us on this information. It was very informative, so thank you. If anyone would like to schedule an appointment with Dr. Scott, their information's there on your screen. You can schedule an appointment at www.mbortho.com, or you can call 855-896-0444. Thank you again, and we appreciate everyone coming and joining us this afternoon. Enjoy the rest of your week. Thank you.